Bill, thank you for this. So my name's Dr. Galloway. Are you happy for me to examine you?
Yeah.
Right, thank you. Pleased to meet you.
Absolutely.
So first of all, I'm just going to have a general look at you. Okay. Can I just see your hands? And turn them palm up for me? Let's have a feel of your hands. And just pop your hands down, just have a look at your face. Okay. I'd like to do just a couple of other tests, if that's okay.
Yep.
First of all, just want to test your vision. So with you looking at me, if you just cover one eye with your hand, and then I'm just going to move my fingers. Just tell me if you can see them moving now.
Yeah.
And then here?
Yeah.
And here?
Yeah.
And then here?
Yeah.
Down here?
Yeah.
And
Yeah.
okay, and just with the other eye. And again, look at my fingers down here.
Yeah.
Still see them clearly
Yeah.
here?
Yes.
And there?
Yeah.
And there?
Yeah.
And down
Yeah.
there?
Yeah.
And there? And there. Sounds fine. Second thing, if I just have another look at your hands, just turn them palm up. If I just tap over your wrist, does that cause any pain?
No.
On this side?
No.
And just pop your wrists like that for me. Just hold them there for a second. Does that give you any tingling in your hands? Just pop your hands down. Can I ask you just a couple of other questions? Rest your hands down. Have you noticed over the last few years that you've had any change in the size of your shoes or
Huge size, yeah.
anything else?
Collar size.
Your collar size, what's happened to it?
Well, I used to take 16 and a half, but it's ended up 18, 19.
Right, okay. Do you suffer with diabetes or
No.
high blood pressure?
No.
And what about suffering with any back pain?
I suffer with back pain.
Okay, well, thank you very much. I'll stop there. Bill, thank you very much for that. So I'm just going to talk to the candidates now and say some of the key features that I found when I examined you. So the first thing when I first met you and just examining you was I noticed that you'd got some prognatism off your jaw. And so my initial thought was, could this be acromegaly? So I started just by having a careful look at your appearance, looking for coarse facial features. I had a look at your hands, and particularly I asked you to turn your hands up, looking to see the size of your hands, but also the texture, the sort of the doughy feel you sometimes find in people with acromegaly. Can I just have another look? I noted at the same time there is tar staining here, and it's always important to note that as a sign of tobacco use. Then I move to the side, have a look at the prognatism from a side profile. It's important to show the examiners that you know what you're looking for. I then started to look for other complications of acromegaly. I examined your visual fields using confrontation to see if there was any bitemporal hemianopia. There wasn't. I went back to your hands and had another look, particularly looking for carpal tunnel. And just looking here, there is actually a surgery from a scar from previous carpal tunnel surgery, although you didn't have any signs of carpal tunnel symptoms when I examined you. I also asked you a few questions about changes in shoe size. You mentioned your collar size had gone up, but other things might be wedding rings that had to be removed. People noticed their glove size may have changed. And I asked you about other complications, whether you had suffered with high blood pressure, diabetes, and back pain, which you had had. So this all fits together with the diagnosis of acromegaly. Bill, thank you very much. My diagnosis for this gentleman is acromegaly, and I say this because of the presence of this prognatism, the coarse facial appearance he has. Examining his hands, he has spade-like features with a doughy texture. In particular, in examining the rest of him, there was no obvious bitemporal hemianopia that I could detect. He does have bilateral scars from previous carpal tunnel surgery. He also in his hands has tar-stained fingers, which is unrelated to the diagnosis, but important nevertheless. On speaking to him about his condition, I asked him about changes in foot size, and particularly he noted his collar size has increased dramatically. So this, put together, is consistent with the diagnosis of acromegaly. I'd like to confirm this by doing an IGF-1 level and proceeding as necessary if that's elevated. So in this case, this is a station 5 case, so it's a short case. You won't have very long to discuss with the examiner. When you do discuss it, they'll probably ask you maybe just 1 or 2 questions. But it's important to have a knowledge of acromegaly. So acromegaly is almost always caused by a pituitary somatotroph adenoma, which produces excess growth hormone. In clinical practice, the diagnosis is usually delayed by many years because it's got a very insidious onset. You may know the patient's got a photograph book beside them on the bed, on the table, which if you ask the right questions, they may show you, demonstrating a sort of classic serial change. In the exam, the sorts of questions you need to be prepared for would be initially the diagnosis. So your initial screening test is an IGF-1 level. Growth hormone, although it's excess growth hormone that's the problem here, growth hormone is secreted in a cyclical fashion, whereas IGF-1 is has a much more steady state of release produced by the liver. And so that should be your initial screening test. If it's elevated, you then go on to do your oral glucose tolerance test with simultaneous growth hormone measurements. If it shows inadequate suppression of growth hormone, you then have got your diagnosis and you need to MRI the pituitary gland. That's the most likely source. The next question is probably going to be, what are the potential medical complications? You may have picked some of these up when you examine them, but it's worth having a list. For example, the arthropathy due to articular overgrowth often presents as back pain and they may have developed kyphosis. Although beware in an older patient, people with acromegaly are more prone to osteoporosis, so they may also have back pain due to an osteoporotic vertebral collapse. About 40% of people with acromegaly have hypertension, and a substantial number will also have cardiomyopathy, and so potentially you could say in clinic you'd like to go and examine the cardiovascular system. You may notice they've got an insulin pen by the bed, because 15% of these people have diabetes. It's due to insulin resistance rather than pituitary insufficiency. And clinically what you may see is the presence of acanthosis nigricans around the neck. A lot of them in conjunction with the prognosticism will have macroglossia, and clinically that can present as sleep apnea. About half people with acromegaly have sleep apnea. We've already mentioned carpal tunnel syndrome, and the one final thing which doesn't normally come up but be aware of is there is an increased risk of malignancy in people with acromegaly. Typically it's colonic adenomas. And the final bit is, I think it's important, they may ask you what potential treatments are available, and probably the mainstay of treatment is actually to remove the tumour. The tumours are macroadenomas usually and potentially cause compressive symptoms, hence the bitemporal hemianopia. So either transfemoral surgery or sometimes radiotherapy, which is what this gentleman had actually had, would be the first step in treatment. That may not completely suppress the growth hormone levels, and it may be you need to use additional medical treatment. The sort of options you have would include somatostatin analogues, so this gentleman's on one of those, but also dopamine agonists can be used, and more recently there's the growth hormone receptor antagonist pegvisomant, which has come on the market. This has been around for a couple of years, so it potentially is fodder for the exam for them to ask you about. It's not used very commonly, and one of the problems is it suppresses the action of growth hormone by interfering with the receptor. It's much more effective than the other drug treatments, but the pituitary tumour may continue to grow in size, and it's also considerably more expensive treatment, so that's limited its use so far.